Hello everyone, my name is Dr.Manikandan. I'm a PGY2 in internal medicine at St. Mary Mercy Hospital in Livonia. And my poster is about a rare case of purulent pericardial effusion caused by Proteus mirabilis. Introduction. The pericardium is a fibroelastic sac made up of visceral and parietal layers separated by a potential space called the pericardial cavity. Purulent pericarditis is a rare disease. The incidence of purulent pericarditis is less than 1%. In a study performed in Spain, only 33 cases were observed among an inpatient population of 593,600, and the diagnosis was not established until postmortem in 14 of these cases. Bacterial pericarditis usually occurs as a secondary infection by contiguous spread from surrounding intrathoracic focus of infection or by hematogenous spread from distant focus of infection. Primary involvement of the pericardium without evidence of underlying infection elsewhere is very rare. And here we present a case of primary bacterial pericarditis caused by Proteus mirabilis and rare diphtheroids. Case presentation. 78 years old female with history of rheumatoid arthritis and hypothyroidism presented to the hospital with complaints of right-sided sharp non-radiating chest pain and progressive shortness of breath for 10 days. On subsequent evaluation, the CT imaging showed a large pericardial effusion with early tamponade and left-sided pleural effusion. Cardiothoracic surgeon was consulted, who subsequently drained 700 ml of bloody fluid from the pericardial space and 950 ml of clear fluid from the left pleural space. The pericardium had a gross characteristic bread and butter appearance as described by the cardiothoracic surgeon. The pericardial fluid and pericardial tissue samples were sent for microbiology testing. Cultures from the pericardium and left chest drain grew Proteus mirabilis and rare diphtheroids. Pathology exam showed organizing fibrinous pericarditis with no signs of malignancy. No other focus of infection was identified, suggesting primary infection of the pericardium. Her clinical course was complicated by atrial fibrillation with rapid ventricular response, which was treated with cardizem. Patient was treated with ceftriaxone 10 days and cefuroxime 14 days for Proteus mirabilis with complete clinical recovery. This is the CT imaging where the red arrows shows pericardial effusion and the green arrow shows left-sided pleural effusion. Discussion. The incidence and etiology of purulent pericarditis have changed significantly in the antibiotic era. In modern practice, purulent pericarditis is relatively uncommon. Gram-positive organisms are the most common cause for purulent pericardial effusion, and gram-negative organism causing purulent pericardial effusion is uncommon and can be seen rarely in immunocompromised individuals. The classic bread and butter appearance of fibrinous pericarditis has been described in rheumatic disease and other immunologic diseases such as SLE, post-myocardial infarct, uremia, tuberculosis, radiation effects, bacterial and viral etiology. This case is a rare presentation where there was no other evidence for extracardiac infection with Proteus species. It emphasizes the need to consider gram-negative species in evaluation of purulent pericardial effusions. Early recognition and prompt intervention are important for a successful outcome. Thank you.